The League of the Genuine Conversations is back with me, your host, Fred Mwema. As always, we are having a conversation about the important but often ignored subject of counterfeits. We continue with yet another episode. We keep changing because counterfeits keep changing. Counterfeits are everywhere. We have just been dealing with the Uganda police and what they are doing to fight counterfeits. We have now dived straight into another sector. We've gone into the medical world. Join me in welcoming here Mr. Frank Buyondo. Frank, you are welcome.
Thank you.
You are one of those people who have been seeing me hosting this show because you're my neighbor near home, and you've been wondering what I'm up to. I think today you're going to find out what this show is about.
Definitely.
How do you feel about it?
Well, I look forward.
You look forward to it. Frank is an orthopedic officer. Orthopedics is bones.
Yes, it's bones.
You break bones or repair bones?
We repair bones.
You repair bones.
Yeah, orthopedic officers, you majorly look at the non-surgical management of bones. People who come with different bone ailments. Then the surgical part is where we find the orthopedic surgeons. And
you've also been in pharmaceutical.
Yes.
You've been a sales manager. So, but bones. So, do we also have counterfeits in bones?
Counterfeits?
Are they fake bones?
Maybe no, definitely
can
not.
Somebody like, because some they are bone replacements.
Yes.
So can somebody, the bone replacement definitely doesn't come from a human being.
You definitely.
It's made in a factory somewhere and
steel.
They give it to you.
Yeah, made out of steel.
Steel?
Yes. Yeah, therefore, in case of surgical management, we are looking at in case someone has a fracture. In the past, that's where our work was major as orthopedic officers, conservative management of someone with a fracture. But with the fast-paced world, people no longer have time to sit in the hospital for months. Now there's surgical intervention.
So what do you put when somebody breaks a bone?
Yes.
I think there's that process where they fit it back, or they put a metal, or they put something.
Yes.
It's actually metal, not plastic.
Internal fixation.
Internal fixation.
Yes. And this is a major made out of steel.
But because steel, because you can have counterfeits in steel.
Of course.
So there's a chance that you can implant a fake
fake
steel in somebody.
Yes. For every growing in field, there is room for counterfeits. It's not the fixators that are on the market are not cheap, and those with counterfeits can take advantage.
Because you can imagine how many people are going to get bone replacements or bone fixations. With all the motor accidents we have been having, a lot of incidents of broken bones, broken ribs. So all these guys go to orthopedics.
Yes.
For treatment.
For management.
Okay, before we go into the real field, you are making some comments. We are having here probiotic. Ever since I discovered probiotic yogurt, it is good for, for the stomach and so on. You were telling me off the set that this probiotic yogurt has a history, but you're also saying that most people are not alert, are not aware about the differences in the yogurt. Can you say something? Yes. Where does this probiotic come from, and what do you know about it in terms of counterfeits?
Would the person who could attribute to the person, this young professor, Eli Mechinkov, is a Russian professor. That was in the early 1900s. He discovered that Bulgarian peasants apparently were living longer than elsewhere. He discovered that people were taking yogurt regularly with their meals. It was part of their meal actually in Russia. If you happen to interact with Russians, it's part of their meals. It's hard for them to do a meal minus yogurt.
When you say Russia, I smell vodka.
Those are good vodka takers. But still back onto the yogurt. The process of processing yogurt. To break it down, yogurt comes with good bacteria. Now, what people don't know, when you come to us, the medical workers, we'll advise you to eat well. Now, the entire science happens in the
mix is in the stomach.
It's in the stomach, or in the. Let's talk about the digestive system, because the science doesn't stop at the stomach. We have the intestines too. Now, you find that our intestines, especially in the large intestine, that's where we find a colonization of what we call the good flora.
A colonization is a pattern. You'll find some guys there called flora. They are bacteria.
They are good bacteria for the common man. We have good bacteria, but the good bacteria coexist with the bad bacteria, the bacteria that makes you sick.
When I have a running stomach,
yes,
that is bad bacteria at work.
Bad bacteria is at work.
What does this yogurt have to do?
Now, this yogurt, in a layman's language, this yogurt comes with good bacteria. The good bacteria, it is the one that combats illness. It helps us combat illness. The good bacteria,
the pathogen,
which coexist with it. Now, the good bacteria will help in the absorption of the nutrients that you've taken in with food. That's why they tell that the nutrients are absorbed from the large intestines, and then they are passed on to the bloodstream. So they'll tell you, eat right. Don't eat junk which has no nutrients. So the yogurt that we're talking about has good bacteria. It helps to fend off pathogens.
Our reports indicate
yes.
that we could actually be having fake yogurt on the market. Anything you can say about that?
I could say one of the things that has compromised the quality of products on our market is the standard of production. The standard, if you will get to test different yogurts on the market, most of them taste differently.
But that's okay, variety.
The variety, but
the spice of life.
But also,
how can we have fake yogurt?
How can we?
How come we can have fake yogurt? You're saying the production. How?
The standard of production. Do people that are producing yogurt observe the right standards of production, or they want to bring something before the public that is just affordable for the masses?
Mass production, profitability.
Profitability. We know our market, people below the middle income status, and most of those are the ones we are looking at. Are they in position to afford the real standard yogurt? So in the process, people will produce the substandard yogurt
and just push it onto the market. Frank, you have been in the pharmacy world.
Yes.
Running urea pharmacy. These are guys from Ukraine.
Yes.
And from your experience, a lot of the sickness that we have, where is it coming from? Do we have a lot of foodborne diseases, waterborne diseases, airborne diseases? Where is the issue? Where should we pay more attention to? Or in all the three?
It all comes with what we put in the stomach. It all comes with what we put in the stomach. If you don't eat right, you'll definitely fall sick. If you do not give the good bacteria what it needs. Now, when you look at if you happen to go to downtown or Winner Market, the tomatoes that they present on the market, they are brought to the market with
pesticides,
herbicides. Herbicides. That white.
So your experience in the pharmacy world is that a lot of your people coming to you, they are coming to get medication to tackle contamination of food, water, air.
Definitely. The factories we have in the market. I remember there's a study that was done, I think it was last year. They said the Busega area has the worst polluted air in the Kampala should I call?
Busega.
Yeah, Busega.
That's what, Masaka Road, Mitiana Road?
Yeah, the most, yes, Masaka Road.
But Kampala itself is one of the most polluted cities.
It's one of the most polluted.
I think we are 27th most polluted in the world.
With Busega coming out as the worst.
So are there a lot of cases,
yes,
inpatient cases? Is there a lot of disease that is coming because of this pollution there?
Apparently, these are things we don't pay attention to.
We don't have data.
We don't have data. We don't pay attention to this. Many people will come to the hospital and upon being checked, they'll tell you don't have malaria, you don't have any infection.
Bacterial infection.
You don't have any bacterial infection, but you have a fever, you are feeling sick. And you find that most people that we have, it is very unfortunate in Uganda that someone can easily walk into the pharmacy and get over-the-counter medicine given to them. Unlike in some countries, you have to go to a doctor first, pay consultation, get checked, and walk into the pharmacy and receive medicine.
I was in the UK one time. I had some issue, and I think the US, and it was a tug of war to get any medication. Sure. I had to have a card. You go on the medical insurance of somebody, and it was a real procedure, a real hassle just to get medication.
Yes.
Now, the practice of over-the-counter drugs that we can easily get, you feel it is a malpractice, it is part of a counterfeit practice, it should not be there, we should not be free to go and buy medicine as we want at a pharmacy?
One, we would make sure that we have the right person behind the counter.
That is one. But I'm saying this practice of we, the consumers, we are watching you now and we are saying, yeah, it's okay. Send somebody to the pharmacy. We even send people to go and buy. You don't go yourself to explain. You tell the maid to go and explain to somebody. So whatever is lost in translation, I don't know. Is that practice okay?
It's apparently very wrong. Because we have so many conditions presenting with similar signs and symptoms. I might get flu, common case of cold. I present with a fever. I present with body aches, the same as malaria. Now, because in Uganda, what we commonly say, you send a maid to. Mami has in the layman's language, omusujja.
Musujja is a fever.
Omusujja,
very generic.
To the common person down there, it's malaria. Now, Mami needs Coartem. Has she tested? No.
No blood test.
Or have you tested? No. Now, if you find...
So who is most in the wrong? The mommy who has sent the maid, or you, the pharmacist, who is giving the medicine?
The person behind the counter, if he doesn't get to advise this person, then that is the one who is in wrong, because you are giving a medicine.
You, the professional.
Yes. And now we find that our medical system has been, should I say, hijacked by business-oriented people. You find that there are targets in pharmacies. If this person wants $1 million a day, you are supposed to produce $1 million.
Irrespective of how it is done. But as we go for the second, for the break, so what medicine can I buy over the counter without a prescription? Panadol for headache?
Yes, Panadol is okay. Flu medicines are okay. Supplements, we're looking at vitamins, multivites. You can walk into the pharmacy and ask for. Then ulcer medicines, you have a case of indigestion, you have a case of, you could say, normally people come, I have a heartburn. If you get worse, you can probably need magnesium, a syrup or a tablet.
Those are okay to buy?
Those are okay to buy over the counter.
But
then cases of antibiotics. Antibiotics, we've seen...
Like what antibiotics? What names?
We've looked at the common antibiotics. Let's look at amoxicillin. Amoxicillin and ampiclox.
Metakelfin.
Yeah, metakelfin used to be in the area of malaria, but we used to get so many counterfeits, especially from across Kenya.
And so amoxicillin, the antibiotic, amoxicillin,
yes.
augmentin.
Augmentin is still it's amoxicillin. And then we're looking at cefixime, which is widely given by everyone in the, even those who do not have the right to prescribe
gentamicin, I think that's an injectable.
Gentamicin, yes.
It's an antibiotic
yes,
as well.
Yeah.
All those need prescription.
Yes, and you find that it is shocking in Uganda. You find people move on the streets with cannulas on their hands. Those should be critically ill patients.
You are not supposed to move with a cannula.
Why is someone moving with an intravenous?
No, if you are strong, if you are a hybrid, you can get an injection, you go to work with your cannula.
Unfortunately, we have abused the antibiotics. And
no,
we're getting resistance.
With the cannula.
Yes.
What is wrong with moving around with the cannula?
With the cannula? Well, I would go for a cannula or an intravenous drug in case someone is probably critically ill or, critically ill. But then...
So you're saying the application of cannula, this common thing, every small ailment, cannula, you're saying it's an abuse?
You walk into a clinic without a qualified personnel, they put a cannula, ceftriaxone. Common colds, cannula, ceftriaxone.
Even small kids right now on cannula.
Kids are on cannulas.
Do they make more money with cannula than with tablet?
For any other person with the same mind, if they came to Uganda, they would think we are a very sick country.
As in we walk around with cannulas?
Yes, we walk around with cannulas. It's very unfortunate. The tablets, we can use the oral route ably. Is someone vomiting? No.
It's the more authentic. We need to take a break.
Yes.
The second segment of the League of the Genuine is right here with you. So please sit back and watch and see if you can learn something. Doctor, the cannula thing for me has left something sour. Why is it that the Uganda Medical Association, the Nurses Association, all these professionals, you guys, why are you promoting abuse of the cannula, which is for critical patients? Why is it that nothing gets done? What's the motivation?
I think it's money. Let's attach the issue of money. At the end of the day, if I'm going to give you a simple course of amoxicillin, the cheapest should be around 3,000 on the market.
For the tablets?
For the capsules or the tablets. Now, if I move to the cannula, the intravenous drug I'm going to give you, the least should be about 50,000. So you can draw the comparisons. Whether the patient
100% more.
Yes. Whether the patient needs the intravenous drug or not, it's the cannula. A nursing assistant will give it. A nurse who has been left to attend will prescribe an intravenous drug. But then there are limitations if you are to follow the protocols in practice. The drug has to be prescribed. But who is the prescribing agent behind the consultation table?
No, but okay, the cannula, are you saying that when somebody is put on a cannula, he gets a higher dose?
Not necessarily, but still, I've seen quite a number of you look at someone's prescription, and many are getting higher doses. These children, some of them, they're not, here in Uganda, people are afraid of paying professional charges. Any child apparently should be under the care of a pediatrician, has to be seen first by a pediatrician. But then, this parent...
A pediatrician, a children's doctor.
Yeah, children's doctor.
But we go to a general practitioner.
Yeah, you might go to a general practitioner, or you might go to a nurse. Well, under limitations, we have the bigger percentage of doctors practicing from Uganda. When you go to the outskirts, the peripherals of the country,
medical officers and nurses are the ones working.
Are running, yes.
But we call them doctor, Musau.
Yes. Everyone in Uganda here is a doctor. Even go to Mulago, anyone with a white coat, person will call them a doctor. Well.
So what you're saying is that not only do we have to confront fake drugs,
yes,
fake antimalarials,
yes,
we lose more than 500,000 Africans every year. to fake antimalarials.
To fake antimalarials, to fake antibiotics.
But you're saying that we then also have to contend with another threat of you, the medical personnel, who are supposed to be our eyes. You are actually closing our eyes and taking us to harm's way.
Yes.
So, are you saying that maybe when the mortality rate among children has been increased by the medical professionals, practitioners, maybe we are having, can you speak to that?
Before we go forward, let's first look at the human resource. Human resource, in the medical field, we are looking at the whole cadres in the industry.
The human resource you name them.
We are looking at the nurses, nursing assistants. Nursing assistants, we have the nurses, we have the lab technician, technologists, we have the doctors, we have the clinical assistants, we have the clinical officers, we have the consultants.
What about below there? These people who clean and dispose of medical waste?
Yes.
The people in charge of that, are they part of the profession, or those are biomedical engineers? Are they?
No, the people who do the laundry.
Because there's also a big issue there. Not just laundry, the medical waste.
Yes.
The syringes, the cotton,
yes.
The what? How is that handled from a hospital? I think that's also a key part.
Yeah, they apparently in training, you are taught the SOPs. They are standards put in place how to dispose of waste. And then we have quite a number of companies, I don't know how they are regulated, that dispose of medical waste.
Because you sell a lot of
yes.
medical things in your pharmacy.
Yes.
Where is the waste thrown? Where do you throw it?
In the pharmaceutical business. Because all pharmacies have a supervising pharmacist, and who reports directly to the governing body, which is the National Drug Authority. And those is supposed to take part in the destruction of these expired medicines.
I derailed you. Let's go back.
Yes.
You are saying the problem where we have the fakes in the medical practice world is the institutions, is the personnel.
Yes.
You are developing your point.
Now, the personnel, what is
wrong with them?
Let's look at the mushrooming training institutions. I've had a chance to interview some of the cadres that have just gone out of school, because like I told you, I was head of sales and marketing in Urea Farm, and you interview this person, and this person has been flagged off to go and manage patients. He cannot prescribe a simple dose of what? Paracetamol to the even to the adults. Now, when it comes to the young ones, the antibiotics are very sensitive. There are so many kids out there who are given overdose, even the adults themselves. Now, the counterfeit professionals that we are getting onto the market, the institutions, do we have the right people to train these medical workers? No. We do not. Some institutions, are they properly regulated? No. We could put in the fact of money. I have the money for the supervisors. Do I meet the standards to train medical workers? Now,
so you're saying there's a challenge with the training?
With the training.
But how does that happen in the same country which has just received kudos and praise from the World Health Organization for containing Ebola in 42 days? We are, Sierra Leone, they fought it, I don't know for how many years. Congo, it was a problem for years. For us, in 42 days or 60 days.
60
Superlative, we are super performers, meaning maybe we have good professionals here.
Of course, we have so many good professionals. So how come
you're saying that?
We have so many good professionals, don't discredit that. But we also have very many
fake ones.
Fake ones. The training institutions, there's so many things happening in the hospitals, in the clinics.
Like what?
That are not registered. Now, I happen to tell you that I'm an orthopedic officer. Back in Mulago, we have a clinic for kids that come having been injected the wrong way.
So the bum is
the nerves are affected. You have those You've seen those who drag their feet.
Because of injections, wrong
Because
injection.
of wrongly injected by the wrong person. Because in training, in your first semester of nursing practice, whenever you go, you are trained on how to administer an injection.
I know of a young man who lost their leg.
Yes.
They had, I don't know what condition, you would see the video there, and then they got, what do you call that condition? Gangrene? Is it?
The gangrene.
Gangrene.
Yes.
It was an injection.
Yes.
The leg got, I don't know, paralyzed and so on, and they amputated the boy's foot.
Because for some, you
That's
might...
what you're talking about.
Yes. You might find the reconstitution, the medicines that are injected. Have they been rightfully reconstituted? Has the person followed the standards in the...
And then have you injected in the right...
in the right...
So the injection is supposed to be where? How do you know the right nerve?
How do you know the right...
No, on the back side. How do you... Give me some science there.
When we divide the buttock into four quarters, and the outer quarter, the upper outer quarter,
is where the injection is
is where
supposed
the
to go.
injection happens.
Not towards the middle.
Not towards the middle, because you risk injecting the nerve.
Oh, the nerves are towards the middle.
Yes.
Just below the spinal
Well,
cord.
all places have
Nerves, but
the nerve,
the concentration.
but the major nerve that will help, that helps in the function, proper function.
So you're saying those kids in Mulago who come when they are suffering as a result of injection, the nurse injected in the wrong
You
place.
could get, if you follow it up, either the person is not qualified, it's a quack nurse, or we have cases where, I remember when we were in training, they have families that force their children into the practice. For us, we want a nurse. You have to go there. Failure. We have some...
But then don't you think it's a contradiction?
Yes.
If there is a risk of injecting in the buttocks and
Yes.
you get the wrong nerve,
Yes.
don't you think then the intravenous is okay? You can see the nerve? Shouldn't we
Intravenous.
be going for intravenous?
Intravenous.
The
Well, you know, I tell people time is quite interesting. It has given us room to the extent that that the drugs we knew back then when we were under formation that could not be given intravenously, like diclofenac. Back then they would tell you don't inject diclofenac into the vein. Right now we have injectable diclofenac that can be given intravenously. So,
But everything is a challenge, Frank.
yes,
Because even when you say, okay, preferable to ingest orally the tablets, but I've had cases of, for example, a common treatment for ulcers is Nexium.
Nexium.
But I've had some reports that there's a lot of fake Nexium, and yet it's also called Nexium.
Definitely. Now,
can you speak to that, and what are we going to do when even the tablets are...
the National Drug Authority, I believe, together with the Pharmaceutical Society of Uganda, which the body that governs the pharmacists, I think the biggest challenge they have is parallel importation.
Parallel importation.
Parallel importation.
Meaning dumping.
Yes. Now so many people bringing parallel imports onto the market. You've talked about the issue of Nexium. I had a case, the late Dr. Mulindo Haman used to work with Makerere University Hospital. He's known to like Nexium from Turkey. He used to say it never works for his people.
Nexium from Turkey.
From Turkey. Then we have one from Sweden, AstraZeneca Sweden. He said the other is a counterfeit. Why doesn't it work as equally as Nexium Sweden?
Are you saying the Nexium from Turkey was a parallel import?
It's a parallel.
And as much as it was?
Yeah, we used to get, because this is an English-speaking nation. If I can get a drug without English literature.
How is the patient supposed to get the instructions in a language they don't understand?
Definitely.
That can lead even to abuse.
Now,
it's in Turkish.
Those are parallel imports. Because if they are to go through the right channels, they are supposed to have that information in English. We speak English. Can even the person dispensing
But
medicine...
you mean Sweden, they speak English? Or they manufacture for the English-speaking countries?
They manufacture for English-speaking nations. So the insert they put in is in English. If they are to produce for Italy, they put an insert in Italian. So whoever gets an action from Turkey should get it right. We need the writings in English. But then, with experience, people are telling you.
So you're telling us
Yes.
not to just go for medicines from any part of the world. We should, as much as possible, try to. Well, we get medicine from India.
Yes, we get medicines from India. Now, my biggest issue, given my time in practice, the Indians got to discover that Ugandans, we want cheap. And they produce cheap. But cheap comes with a cost. Does it meet the standards?
Are the active ingredients in?
Are the active
Isn't it
ingredients
prone
in?
to counterfeiting?
That is counterfeit. Do they meet the standards? In the process, there are so many people that are going to take advantage
And push whatever it is they want to push.
whatever they want to push onto the market, and they are there. And most of these manufacturers, they know the counterfeits on the market.
So you're saying that we are bringing counterfeits onto ourselves
Yes,
by our sensitivity to price and so
To
on,
price.
and not looking out for quality.
for quality.
Let's take another break.
Yes.
We're back with the third and last segment of this conversation with Mr. Frank Buyondo. He is in the pharmacy world, he's in the orthopedic world, he's in the medical world. Talking further about counterfeits in the medical world, we had an experience here. One of my partners here in the law firm a few years ago was diagnosed with some type of cancer, and so you can imagine the panic that we had, and so we got her out to India for treatment, and to our utter shock, the Indian doctors said, no, she's not sick, she had no cancer. The issue of counterfeits in form of lab results, what do you say about that? It appears to be a common thing.
Now this all goes back to the human resource, the counterfeit human resource we have on the market, and compromising on quality.
Counterfeit human resource.
Yes.
So somebody goes and changes the results and says positive?
Because I would say there are people who are practicing without their results. I bought results or NASA results. That's a counterfeit medical worker. And then, is this person trained from the right institution?
No, but Frank, what I'm saying, if this is the machine,
Yes.
this is a machine that checks
Yes.
whether you have a certain condition. I may not be qualified,
Yes.
but the machine is here. I can't corrupt it. If I apply it to you, it should give me the right result.
Yes.
Is the problem, I don't discount that there's a problem with the personnel. Possible there's a problem. Is the problem with the machine that is giving fake results?
Yes.
And how does a machine become fake and give fake results?
All right then. Now, in laboratory practice, one I could mention there are different cadres. There are lab assistants, there are lab technicians, and there are lab technologists. Now, we have the machines. Is the person operating the machine the right person to operate it?
That is one level.
Yes, that is one. And then, quality assurance. How do we maintain the machines?
Maintenance of the
machines.
Oh.
Now, under standard practice, for most of these, what we could say like accredited laboratories, you find that there has to be routine maintenance
and service
of these machines, maybe every quarter or every after 6 months. But I know there's so many institutions there that do not. They only call in someone to work on the machine after it has broken down, not to maintain it.
Frank, you're
Yes.
saying that
Yes.
the reason we have fake medical results in Uganda could be down to servicing and maintenance of the machines.
Of course. That's right.
We want to save costs because it's costly to service these machines.
Definitely. Now, like I've told you, the medical field has been hijacked by business people. Now, and they want to maximize profit. The staffing they are going to recruit.
No, before you go to staffing, I'm very interested in
the machines.
Maintenance.
The maintenance.
So, because I used to wonder.
Yes.
Like I was in Nairobi sometime talking to some doctors there, and they were like, you guys in Uganda, your doctors, you're always having fake results. And so it's the machines, actually.
It's the machines. Now you look at, we have, Makerere University has an undergraduate program of biomedical engineers. These biomedical engineers are supposed to come. They're supposed to be hired.
Maintaining the machines all the time.
Such machines. They specialize. Someone would go into radiology, someone who specializes into lab equipment, to mention the few departments in the hospital setting. Now, someone buys a machine. It is run.
And they're expensive.
And they're expensive.
Many of those machines.
Yes. And some of these machines, apparently, I was in, there's a while back I was interacting with a lab technologist. This is a degree holder. And he was operating one machine, and he tried to look it up on the internet. And he could not find like the serial number of that machine.
So it was a fake?
That is a fake machine. That is...
a machine is here in a hospital?
Yes.
But the lab technologist tries to check.
Yes.
Because all these things, you get it on the internet.
Definitely.
And he couldn't find a trace of this machine.
He couldn't find the trace of that machine.
And this is a machine working on Ugandans and churning out whatever results.
Of course, it is giving out results. It's giving out results. Now you find that in proper maintenance of these laboratories, a hospital, let's say, okay, any hospital, they're supposed to get, like, once in a while, get results, like for five samples. Get your results. Visit your sister laboratory and compare. That is maintenance. Compare notes. Has their machine given
the same kind of result for the same sample?
The same sample.
And you're saying this is not being done?
If not, it's not done. It is, I can't say we are 100% not practicing that. There are institutions that do that. But there are so many that
are not doing it.
Are not doing it.
So are you telling me and the viewers that when you're going to do a lab test in a hospital, in a lab, whatever it is, try to find out also, maybe ask if possible, I don't know. How do I know that this lab is doing the servicing? How do I push?
Well, it's hard for the common person to know.
Because I won't know if it is serviced even.
Even the person who's running the machine might not be the technical person to run it. Because you find in the lab, most lab settings, you have this lab technician takes off the samples, blood samples. He runs the blood samples. He runs the urine samples. He runs the biochemistry samples. Now, one person cannot do all that. One person cannot do that.
You mean the person who takes the stool sample, the urine sample, they're supposed to be different or what?
Now, I would, depending on how active the traffic in the hospital also matters. But still, you find that even in government hospitals themselves have lab technologists. But when you go to, I think, to the public service, they have no room for lab technologists. They have room for lab technicians.
What's the difference?
Lab technician, this is a diploma holder.
And lab technologist is degree?
Yeah, degree holder. Now, for each level, and then there are certificates. There are certificates. Now, you might find in a setting where there is a certificate holder trying to interpret results of a level of a lab technologist.
And so whatever he interprets, he puts in, he writes down and says.
He will definitely run. At times, these people are supposed to assist in the interpretation.
So what I'm hearing,
yes,
is that this area of the lab, we underestimate it.
We underestimate it.
Actually, in our medical practice
yes.
here, and that's why we're getting a lot of these false. Even their issues, just sheer negligence, mislabeling.
Mislabeling.
They get Frank's results and give them to Tom.
Now, if
like there was a case I saw,
yes,
where some doctor was telling me a gentleman was waiting for his results, and when the results came, the test was positive, pregnant. So meaning they mixed.
You can imagine
a woman's results and gave it to the man that he was pregnant.
You can imagine.
So the back to the other thing of the institutions, the training.
Yes.
Even during COVID, you saw a lot of, you call them what? False positives, false negatives.
Yes.
All this was a function both of the machine and the personnel.
And the personnel. Have they taken off the right swab? Is the person taking off swab technical enough to take off that swab? Have you done the right insertion of the swab? Because for the fear of pain, someone would just stop just here, then take off a swab and then we'll go.
And yet you're supposed to go.
You get me now. And then the understaffing. If we have a very busy medical center run by maybe one lab technician, is supposed to give you all those tests. He's supposed to run, because apparently they took one of my children to a clinic, and had a confrontation with one of the clinic officer behind the consultation table. He had asked for so much. Now you find that you go to, because of the interest of money, the medical officer would request for so many tests. You do malaria test, you do typhoid, you do brucella, you do CBC. So someone has come in with diarrhea, and you want this lab technician to run about 10 tests of one patient. Remember, there are other patients that are in waiting, that are in line. So he's supposed to report the 10 tests. In the simultaneously running tests for other patients.
So that's a heavy workload.
A heavy workload. Understaffing. And now if you happen to have known the right trained personnel in that laboratory, you are bound to get false results.
But Frank,
yes.
I'm also told that there's a practice of doctors running unnecessary tests just to make money. You go with a headache,
yes,
and then they check, I don't know, heart, everything. They check 10 tests, even which are not necessary, just to rake up the bill.
Yes.
What's your comment on that?
Does
it happen?
Like I've told you, we've been maximizing profit. The hijacking of the medical industry by business-oriented people. You compromise. You know, these medical centers are now setting standards that we want like 50 million in this target. This
you
month.
Can imagine a hospital
yes.
which is supposed to serve people.
Yes.
It will have a target.
It will have a target.
So you, as the CEO,
yes.
general manager of this hospital,
yes.
if you don't bring in 100 million that month, you're incompetent. You'll be fired.
Yes.
So meaning you have to do whatever it takes
to get the 50 million.
Is that the reason why a lot of mothers these days are subjected to this C-section?
C-section.
And not almost everybody is giving birth by C-section.
Yes.
Is this a motivation? Is this counterfeit?
It's a motivation. It's a motivation because I could say that industry is full of brokers. Full of brokers. You might have a nurse attached to a given doctor who loves money, who likes the money. So immediately, I have colleagues, I have friends that have produced birth naturally, but they were booked for cesarean. At one time, I was interacting with this this one person, he's an anesthetic officer. He told me at some point they had the mother booked for cesarean, produced wine in line. She went into labor.
And
went into labor. and produced as she was waiting for a cesarean section to be done.
And she pushed naturally.
She pushed naturally. So the industry is also full of brokers. The brokers, how much do I get? A normal birth average would be 500,000. A cesarean on average could be 1.5 million. So you can weigh.
300% more expensive.
Yes. So now, what do I take? If I take mother through normal birth, I'll take less. Versus the commission I'll take when I book so many cases.
So a lot of these women who are being subjected to unnecessary cesarean, isn't this affecting in a permanent way or some form their health? Because why should you be cutting?
Of course.
Or is it a safe practice?
It is a safe practice if the mother and the baby are in danger. And they cannot, the mother, everything has been, they have proven beyond doubt that she can't push the baby. Now, but you find many, well, we don't attribute this only to the doctors or the medical personnel, but also the women.
Actually, that's what I was going to say. Many women, modern women say, for me, I'll not go through the pain, just cut and remove the baby.
Definitely.
So the women are also faking it.
The women are pushing for it. I do not want to go through the labor pains, so you just cut me. And you find that many have, some have set the standard, I'll have 2 children. 2 children, I can afford the cesarean. I can push my husband to pay for the cesarean, disregarding the effect it has on their health.
But you cannot blame the women without blaming the husbands.
Yeah.
And with the men also negligent.
Yes, the men.
We are not participating.
We are not participating.
And we are encouraging this fake practice.
Yes, actually I know of a hospital whereby when you go to immunize your child, they work on a couple first. Even if there are mothers who came an hour ago, they work on a lady with a baby who has come with her husband. So we're trying to encourage fathers to take
more participation.
More participation. Don't leave it to the lady.
But with this culture nowadays of many women, they don't mind. They want a child. They can be single.
Yes.
They don't want the hustle of a man and husband. Many single mothers is a reality.
We have so many. Actually, I often question women that come to me. You find a girl who says, "No, I want to become pregnant." I always put it before them. Is that the right person for you? Have you discussed about it? There are those who would trap a man.
They just want a baby.
They just want a baby.
But very soon you'll be sued for discrimination, because we are all equal before and under the law.
Yes.
So if you're going to make those coming with a man to get preferential treatment,
no, in a way we are
discriminatory, because they are all mothers. That's why under the law we no longer have illegitimate children. All children have equal rights, whether born in wedlock or outside wedlock. They are treated same.
There are people who we want to make the assumption wrong. Probably I stand to be corrected. This might be a wrong assumption. We'll try to take the assumption that every woman or every lady that has made the decision to have a baby has her man with her. Well, we have cases of rape. We have cases of unwanted pregnancy, one night stands. Comes with but they want to
also have fake postina.
Yes, and then we have actually. I know of a person who bought. At times, it's not about the fake postina or the fake emergency pill, because right now there are so many emergency pills on the market. Looking at counterfeits, there's so many fake emergency pills on the market.
Anti-pregnancy.
Because this is a booming market. This is a booming industry. It's a booming market. Many people who disregard HIV and take part having unprotected sex are very many. So they know there's an emergency pill. And the emergency pills are abused, because apparently a person is supposed to swallow an emergency pill once in a month.
But so these guys are swallowing after every...
You find those who walk into the pharmacy You will find those who walk into the pharmacy, and almost every week they're taking the emergency pill twice.
Oh.
Yes. Now, is the person interested in money who is working on this lady or not? Yes, of
and
course.
side effects? Any side effects on the young girl or whoever is taking it?
We have many women presenting with hormone imbalances.
Because that emergency pill is a hormone.
Yes.
So if you intoxicate yourself with too much of it,
creates an imbalance.
maybe you'll never give birth even.
It creates an imbalance. And you find many women who have, there's some in my period, but they'll bleed for a month, which is not right.
It is abuse.
On average, yes, on average, any lady who has gone into her menses should bleed from 3, maybe at most a week.
But somebody bleeds a whole month.
But someone bleeds a whole month. Now, these are abusing the contraceptives. Now, the counterfeit, the fake personnel behind the counter that wants money will just recklessly give away the emergency.
Once we get into the issue, Frank, yes, we have to close, but yes, I can't let you go before you comment on Dankani. Yes. Those are our drivers of counterfeiting. Which, according to you, stands out? We don't know the concealed dangers, the affordability, we cannot differentiate. Are we negligent? What do you think? Well,
the dangers of counterfeits in the medical field, I should say almost 90% apply.
Now, do we know them? Is that the reason why
yes,
counterfeiting is growing? Is it because we don't know the concealed dangers, or because we cannot afford, or because it's normal?
The masses, even those we say are land fellas, don't know
the dangers.
The dangers. And then, to make matters worse, we have the issue of affordability. We, you know, in the industry, we have an infestation of cheap fake medicines, and that is doing a disservice to our people. Why would I got a client who had high blood pressure, who was hypertensive, but they had taken, he used to get affordable antihypertensives, but they could not control his pressure until we made a choice. The doctor advised him actually, go to the pharmacy and ask for a European brand, and he managed to stabilize his pressure.
What medicine was it?
Remember, by then it was amlodipine, and it was amlodipine.
That was the fake one he was taking?
And he was taking a cheaper generic. He was taking a cheaper generic. I don't remember because it's been like 8 years ago. And then he was on losartan, also an antihypertensive, but the doctor advised him change and buy maybe a German brand. And he managed to contain his pressure. So that means the other cheaper generic, is it helping?
Not work, no active ingredients,
no active
maybe
ingredients.
Phosphate. Frank, we have to stop here.
Yes.
This program, we cannot enlarge it because I'm really in tune now with what you're saying. But your message to us, we've just begun the year. How should we live this year better? And how do we avoid counterfeits?
I would advise, going forward this year, I would advise the masses to try and eat right. Eat right. Actually, they advise you to eat fruits on a daily. I know this appears as a luxury to many, but it helps. A glass of yogurt a day, if you can afford, would help, because healthy bacteria in the stomach will give you a health well-being. And then call on to the authorities. The level of counterfeit on the market. Speaking for the medical field, the pharmaceutical business, I would call on the National Drug Authority to come and enforce, come onto the ground. There's so many counterfeits. And then advise our patients, consult a doctor before you walk into a pharmacy and just blindly receive medication.
He says consult a doctor, but remember, consult a genuine doctor. We have a lot of fakes as well. We would like to sign off. This has been a conversation with me, your host, Fred Mwema. We have been talking about counterfeits in the medical world. We hope you have learned a thing or two about how to keep yourself and your family safe. A lot of fakes in the medical world. If you like what we are doing, please do subscribe. We rely on your continued support. Do share our videos as widely as you can. And please remember to put the notification so that you are informed every time we have a new episode. As always, don't be fake, buy and sell genuine.